Feeling trapped by outdated cancer treatments? You're not alone. Welcome to OffscriptRx, where we break free from the limits of conventional medicine and open the door to revolutionary repurposed medications. I'm Dr. Nathan Goodyear, and this podcast is about disrupting the cancer care status quo. It's time to reclaim your health with treatments they don't want you to know about. If you're ready for a future of real possibilities, you're in the right place. Rethink repurposed medications. Rethink reality. Dr. Nathan Goodyear here with the esteemed Joe Nowell. We are two doctors talking drugs and doing drugs, right, Joe? And this morning, I'm doing some caffeine. So there you go. We're fitting with the title.
Exactly.
There you go. So when we talk about doing drugs, they can actually be good, healthy things that are good for your brain. Caffeine, a good cup of Joe. But and I'm with Joe this morning, so we could call it a cup of Joe with Joe. But there you go.
That's right.
Yeah. And again, it's early for me, but I don't want to miss these opportunities because first, Joe's a dear friend, but it's an opportunity to talk repurposed meds here at OffscriptRx, because what we want to do is we want to empower you to get the best out of your healthcare. We want to bridge the gap between conventional, what most people will call standard, and then the quote unquote alternative. Now, when people talk about repurposed medications, there's certain things that come to mind. Ivermectin would be one, mebendazole, fenbendazole. These would be the things that come to mind. But what I want to do is kind of open that up a little bit and bridge the gap about how we can get this concept of repurposed medications, which is very evidence-based, which we're going to talk about a study right here, how we can bridge that into the conventional mindset and get them to open their mind to this idea. Joe, welcome back to OffscriptRx. Always good to have you.
Hey, thanks for having me. It's always fun.
And as I've said, you know, new digs on the eyes there, new glasses.
That's right.
So
my wife wants me to look scholarly.
Scholar. Well, you got to say it right first.
Scholarly.
That's right. That's East Tennessee scholar. You're hollering from the scholarly.
That's right. Yeah, exactly.
Oh, Joe, it's good to talk to you again. How's everything in East Tennessee? How's everything at the Fresh Pharmacy in Lenore City?
Oh, doing well. Busy.
Yeah,
and it's really, we do a lot. Since Tennessee passed a law on ivermectin, so it's 4+ years ago. The first 2 years were, COVID related dosing, and then it kind of shifted to cancer, and then that sent us, down rabbit holes. And I've said this before. If there was a good thing about COVID, if there is a good thing, it was it forced us to look at this particular medicine like we've never looked at before, and it has yet to not impress us from one day to the next with its results and the breadth of how many things it can treat. I think I don't even know how many, maybe up to 30 different things. And
I think that's why the medical establishment is so scared of it, because some of these repurposed medications, they have such low side effect profiles, and they appear to have such broad. I mean, ivermectin, the way I see it, natural therapies, Joe, have such broad touch points in helping, so that they'll help. With inflammation, they'll help to, balance the immune system. They'll help in signaling. They'll help in, glucose control, metabolism, deregulated energetics. So they have all these touch points where conventional medicine, it says, okay, A to C, we need to block B. That's their approach. But natural therapies, or a more holistic strategy, they're going to, hit 20 points, not block them, but modulate them. And I see ivermectin more in that light than I do a conventional medication. It's hitting multiple touch points, which I think is, from a clinical standpoint, because you're on the front lines as a pharmacist, you're seeing the direct feedback from patients of whether these things work or not, right?
We are. And again, it's I tell them all the time. I say, can't listen to me. I'm biased. I get a chance to work with this on a daily basis, and um, I'm constantly in awe of what this does, among other things. I mean, artemisinin, methylene blue. There's a bunch of things that kind of opened up um, our eyes to using these medications like we've never done before, and um, I'm just the potential is huge.
Yeah.
And what I think I'm impressed with the most is is the fact that most of the medications that we're dealing with, even the two we're going to talk about here in a minute, uh, they're generic. They've already gone off patent, and most of the medicines that we're dealing with are off patent meds, and that means that in the in the world of big pharma, or as we like to say, big pharma, um,
That's a new one.
the the how do you say this? In their world, if it goes off patent, it also loses all effectiveness,
Wow. Yeah.
right? And so then these drugs get swept under the carpet, so to speak, and then we forget about them, and then we refer to as the floss chick or whatever comes to the doctors and say, hey doctor, this is a new drug, and it's a new patentable medicine, and here's all the the fancy food and all the bling that goes with it, and then they follow everything that's the newest patentable medication, the one that you see on television that's being advertised, and then the one that's off patent is forgotten about. Now, here's the beauty of that. The beauty is that we have data and years of at least 14, before the patent runs out, of experience and side effect profiles and mortality and morbidity data. And we know how to wield these medicines. Just because they go off patent, there's no reason to quit using them. And we'll find this out when you start talking about propranolol and celecoxib, otherwise known as Celebrex. These are drugs that totally change the game, especially in this particular realm that we're talking about with colorectal cancer, which we're seeing a lot of. More patients are coming in. I had a young girl come in with rectal cancer. She's probably in her 30s, and we're currently working with the doc on using ivermectin and mebendazole and I think or fenbendazole. Anyway, one of the two. They're in a variety of things, and you were talking about probably so far a 50% shrinking the tumor without operating so far. Last time I checked in, but these medicines that we're going to talk about here are totally changing the game as far as especially when you're talking about sort of a 5-year post surgery metastasizing issue that shows up again. It's like, oh yeah, I had it, got it out, I'm fine. And then 5 years later, then you're like, oh no, it's metastasizing all throughout the body. And now what do we do? And we don't need that. And if we can use generic medicines that have been proven safe, that are cheap, I mean, or the right word, inexpensive, you don't have to pay an arm and a leg for them. And we already know their side effect profile and how to wield them. Why aren't we doing this?
Well, therein, I think, lies the problem, Joe. It's, we're dealing with an issue where the profits are over patients. Profits are superseding patients, because what's happening here is, it's not that it's lost its efficacy because it's gone off patent. It's just it's lost its profit margins. And so its potency is, the potency succumbs to the profit margin there. And so that's what happens. They're looking then to the next drug. And that's why at the end of this, they talk about, well, we need phase 3 studies. It's like, why? Why? Incorporate this now. The safety profile. You know how to dose this. Incorporate it now. The only reason why you're saying that is because you don't want to be the one that says this needs to be introduced into the quote unquote standard of care now. And I want to touch on a point that you mentioned there, Joe, real quick, is, you talked about basically the changing demographics of some of the cancers that we're seeing. And what I tell patients all the time is, look, the cancer of today, it's not the cancer of yesterday. It's just simply not. We're dealing with too many force vectors that are changing the dynamics of cancer. Of course, COVID, the pandemic, is one of them. There's many others, though, that are playing a role in this. And when you look at some of the sentinel cancer types that are part of this changing demographic, colorectal cancer is front and center, number one. I mean, it is clearly a changing patient population that are susceptible to it. Now, it's really interesting. People will go, well, why is it changing? Is it all the pandemic? And what we fall into is we fall into this magic bullet theory that we've been trained so long to think about. Paul Ehrlich, back in the early 20th century, said, let's treat one disease with one chemical. Okay, that's where actually chemotherapy came from. Chemochemical therapy. Didn't have anything to do with cancer. It had everything to do with syphilis. So I imagine you see a lot of people coming into your office for your clinic for syphilis, right? Yeah, no, it's something we don't see unless it's some kind of specialty clinic, and really there probably don't see much at all. And so that magic bullet theory came from that concept, and the problem is that continues to permeate our mindset, and you see this in the practice of medicine, right? Well, one disease, one treatment, one block, one agent, one sequence, it's like you think cancer's going, oh, darn, they got me again. They blocked B. I was going to C. No, it's doing a million things at the same time. But the reason why we do that is because of the approval process, and honestly, because of the simplistic thinking that we bring to the table that cancer doesn't abide to. But I think the simple thing there is that what we're dealing with in cancer is not a disease of aged, because when you look at colorectal cancer, it used to be a disease of 60s, 70s, and 80-year-olds. And what we are now seeing is, no, what it's always been is a disease of aged cells. And so we're just seeing the accumulation of aged cells in people in their 20s and 30s. Now, breast cancer, here it is, towards the end of August, and upcoming is Breast Cancer Awareness Month. And, we're also seeing similar shifts in the demographics for breast cancer in younger women. But I'll surprise you with something. Censorship is still happening today. So if you're out there and you want to help this movement, share this with @RFK, because, if you say the word ivermectin, you may say, well, that's not a 4-letter word. Well, it's a 4-syllable word. And apparently, Google and others don't like that word. They are censoring the fire out of my online digital course, where I talk about ivermectin, mebendazole, fenbendazole, mebendazole versus fenbendazole. But what's really interesting about that discussion, Joe, is we're talking about the pros and the cons. And we're talking about individual studies. We're talking about how they target the hallmarks of cancer, how they target the hallmarks of aging, which are ideas born out of sentinel studies published in the 2000s. And yet Google's algorithm goes, no, you can't talk about that. You can't talk about that. And so the company, Metabolic Regen, so go to metabolicregen.com today, where you can find this online digital course, and more will be coming. It basically just killed their SEO. So basically now they're trying to find a workaround. But that shows you that censorship is still today. It's just they've kind of put it behind the front. They put it behind the house. You can't see it. You can't smell it. You can't hear it. But they're still actively working to censor.
Well, isn't that the scientific process, right?
Censorship?
No, not censoring, allowing discussion to take place.
Yeah.
Let's say you're totally wrong, and that ivermectin is nothing more than sugar water. Well, let us work it out. Let us talk about it until the nth degree. And, there shouldn't be anything to be afraid of, because if it doesn't work, it doesn't work. And no one gets cured of cancer. Not cured, sorry.
Yeah, don't say that
no
word.
one has, right. No one has the outcomes that we're seeing. Of course, it must be placebo effect. Well, if that's the case, let it pan out. That's what debating things back and forth are. This idea of don't let them discuss things, and don't let this what they determine as, hogwash, or conspiracy, or I don't know, dreaming. They're like trying to protect everybody. It's like, no, just let the process go, and the facts will lay out the issues. But no, we still run into this. I don't know if I told you this or not, but I was asked to give a speech. This is probably a year or two ago. I've lost count. And not too far, maybe 30 minutes down the street. But the closer you get into Knoxville, right?
Yeah.
And the further away, I guess I don't know, more conservative it is, and less conservative inside the city.
Yeah.
But I was going to give a talk on ivermectin, and just sort of a rehash of where we're at with COVID. And so they were like all excited, and they start putting it on the web. And then somebody chimes in and says, well, it's killing people, and it's for horses, and, all that kind of stuff. And all of a sudden, I hire a replacement pharmacist, take the day off, and I'll go down there to give a speech. And it was like a little lunch and learn. And I get there, and they're like, yeah, it's canceled. I was like, well, thanks for calling. Let me know. And they were canceled because of the image. And the boss of the facility was afraid for her career, and I thought, wow, it's alive and well. It's right here. And I have a degree to dispense medicine, and I'm going to talk to you about medicine. and but they were more concerned about inhibiting free speech and protecting their image than allowing me to bring these people up to speed on what.
Oh, come on, Joe.
What the data is.
They were about preserving the scientific conformity, the consensus, the panel of experts that had determined that everything else outside of their minds was quote unquote conspiracy and alternative. And that this was actually a conspiracy of horses coming together and veterinarians coming together to steal the market share of antiviral therapy. That's what this all was.
Yeah, and remember, the state of Tennessee had passed a law that allows us to dispense this. So not only do I have law behind my, I've got a degree and law, and I'm just, hey, this is a freebie. If you want me to talk, I'll talk. I'll come talk. But it's still happening, and of course you're still seeing it when the social media side, and
yeah,
I don't know, maybe things will change.
On the social media platforms, it's not near as bad. I mean, X, Instagram, Facebook, they're still open. There's the ability to have open dialogue, critical thinking, but what we found is with the Google that the conformity was there. Speaking of speaking, I'll be speaking at the Metabolic Health Day conference. It's a 2-day conference that Dr. Nasha Winters is putting on in Tucson, Arizona, at Lowe's Hotel. I encourage you to go to Metabolic Regen. You'll find that there, but search for Metabolic Health Day Conference, because Joe, we're going to be talking about why we're seeing such an issue with disease, such an issue with cancer. And I believe a lot of it is related to the concept of industrialized farming versus regenerative farming. And so that's going to be kind of the topic, is how we move forward in the next days to decades to actually change the health trajectory. And so RFK's got basically a big task ahead of him, Health and Human Services, to basically change the trajectory of medicine. I don't believe that could be changed in 4 years. I think we can make a start. But one of the things that I'm going to drop there is about a 4 to 40 day to future plan where we can actually change and build a legacy for our children, our grandchildren, our great-grandchildren, and beyond, one that promotes health and not disease. And of course, repurposed medications such as ivermectin and others tap into that. So join us there. You can go on there. You can actually join us, and you never know. We may have some surprise visitors there. And by the way, Joe, I'm going to be doing a ton of podcasting there. So we're going to have a ton of content coming out of there. It's going to be super, super exciting. So, well, let's dive into this, because I always enjoy our conversations over Joe. By the way, we used to do this, did we not? When I lived in Knoxville, We would meet. Was it Thursday or was that Saturday? We'd meet and we'd have
30,
coffee.
Thursday mornings, pretty much the same time at the Panera Bread, I think it was.
Well, for you, it's the same time. It wasn't open my time, but they'd be going, "What are you doing here?" They'd call the cops.
That's right.
But
Yeah,
yeah,
every Thursday
we'd
we'd
have
sit and
coffee.
talk about whatever.
Yeah, and I believe we actually talked about a podcast, and this was years ago. This
Yeah.
was years ago, and here we are now doing it. I think this is actually our eighth or ninth episode.
Really?
So
Okay.
we'll have a party when we hit 10.
All right. Sounds like fun.
All right, so this particular topic here, we're going to expand your thinking on repurposed medications. I want to entitle it "Block Stress, Block the Spread." Now, this was a 2020 article looking at two combination repurposed medications. Again, check out the show notes; you'll find the evidence there. And again, we're also going to put other studies there where you can take your own deep dive, your own research rabbit dive, if you will. That's the AI tool I use. A lot of fun. It's called perioperative COX-2 and beta-adrenergic blockade, improves biomarkers of tumor metastasis, immunity, and inflammation in colorectal cancer. Get this, a randomized controlled trial. Oh, there's the gold standard of conventional research. Joe, tell the listeners here, our followers, tell us about these two drugs from a kind of historical perspective. What are they, and how do you typically prescribe them? Because there's something that you see quite a bit, huh?
Yeah, absolutely. We'll start with propranolol. Propranolol is what we call a beta blocker. It developed in the 1950s. I did do a little research because I didn't really know. But interesting, the guy that came up with propranolol also was given a Nobel Prize, which is kind of cool. Yeah, because it was the first time they'd actually been able to treat heart issues with anything other than a nitrate.
Oh,
And of course, and that was 1950s, and then I think he got his Nobel Prize in like 1988. But anyway, they use it for hypertension and cardiac arrhythmias and myocardial infarctions, migraines and portal hypertension, anxiety, essential tremors, hyperthyroidism, and pheochromocytoma. That's just a few. And then, of course, we're going to talk about the cancer side.
yeah.
And what it does for reduction of catecholamines and the whole 9 yards. So, and that's really where we want to pay. Of course, I'm looking at some studies we've got on this, and of course, you're referring to this particular study, the post-operative. I don't know if it's backwards this way or not, but
Well, you're from East Tennessee, so that fits out perfectly backwards.
yeah, right. But yeah, so what happens is it blocks the catecholamines as far as the mechanism of action, and things like adrenaline and noradrenaline. And if you think about that, it inhibits what they call inhibits the sympathetic. Gosh, I can't even speak today. Sympathetic effects,
Yeah.
and you kind of think about this. And I was digging around trying to figure it out because it's the half life is 3 to 6 hours, but it's highly lipophilic, and the maximum of dosage is removed via hepatic extraction. But after you swallow it, only 25% of it's actually getting through the system. But still highly effective, decreasing platelet aggregation and reducing migraines by 44%, and anxieties and portal hypertension. What's interesting,
And this is just all with propranolol that you're mentioning. You're not even touching on Celecoxib yet.
Right. This is just propranolol, and very safe. Just like anything, all drugs are controlled poisons. But the beauty is that we've known about it for quite some time, have lots of experience with it. But it's one of the advantages of this. It decreases the peripheral conversion of thyroxine to triiodothyronine. Big words. That means it inhibits T4 to T3 conversion, which is interesting because they use it for hyperthyroidism, right?
Graves' disease, yeah.
Yeah, which is interesting. And I think there's more to it. I think sometimes we probably need to take a bigger dive down that pathway. as I was kind of marking these things, and of course, I did not know that because
I
we've
bet it
never
blocks.
used it that way.
I bet it blocks T4 to reverse T3 as well, Joe, because reverse T3 is a great inflammatory marker that we follow in cancer. And this, by the way, there's so many labs that are readily available to your doctor that give great insight to treatment, prognosis, treatment efficacy. Reverse T3 is one. The neutrophil lymphocyte ratio is another. These are readily available labs, and yet nobody looks at them.
Yeah.
And everybody goes, well, how do I know I'm doing? Look at biomarkers, which are historically inaccurate. But when you look at some of these, they're very, very accurate in evaluating, shout out at Nasha Winters, the terrain of that environment. So, Joe, that's fascinating. I bet it blocks T4 to reverse T3 as well. You're exactly right. It's in the protocols for the treatment of Graves' hyperthyroid storm.
Well, if it did, I mean, reverse T3 was inactive in the first place. Whether it didn't, it's almost irrelevant. But if it blocks the T3, that's where your activity is. So I don't know. It's something to ponder. I think there's more to it that we could probably end up doing a podcast just on that effect. That it's like, how could we manipulate that in certain cases from an advantageous standpoint? But
No, you're
another
exactly right.
another piece of information that I dug up on this was interesting. In 2008, they discovered that propranolol was used in infantile hemangioma, which turns out to be, says here, was associated with less cancer-related physiological distress in patients with newly diagnosed cancer, and potential benefits of preoperative propranolol decreased preoperative tumor growth have been suggested. And of course, this is in 2008, and here they're getting a hint that there might be a connection between propranolol and cancer activity back then. Let's see what else we got here.
Well, bring into the mix Celecoxib because we're gonna, because I want to. I
got a whole nother research on this one.
Yep.
So, approved for by the FDA. Oh, of course, all these are approved by the FDA, which is good. Right. Hence the term repurposed. Right. So, approved by the FDA for polyps in colorectal cancer. So they actually have acknowledged it, and specifically for cancer. When you use in higher doses than normal, locks into specific death receptor. Y'all talk about that. Or what they call it anyway. Sites on cancer cell membranes that causes them self-destruct. Right. And it's shown that it sensitizes cancer cells and cancer stem cells to chemotherapy. So you have advantages from several different angles. That was a study, I think, from Emory School of Medicine. They showed that it was effective against lung cancer, brain cancer, prostate cancer, and breast cancer. Looks like that was around 2017. Let's see what else we got here. Let's see. Locks into a molecular keyhole on the cell surface, dubbed the death receptor, which I thought was interesting. I haven't heard that term. But
most of these, where people may notice Celecoxib or Celebrex is that, being approved in 1998 is anti-inflammatory and kind of anti-pain properties. So whether that be, osteoarthritis, some type of sports-related injury, rheumatoid arthritis, acute pain, right? Women with primary dysmenorrhea. I can't talk either this morning, apparently. We've not had enough of our.
This is like an herbal tea, so there's no caffeine. I need some.
Well, then
let me go back and we'll talk about Celecoxib from the simple definition that I use when I'm talking to my patients. If they're saying, why would I do this as opposed to, say, ibuprofen or some other NSAID or non-steroidal anti-inflammatory drug? And the description is simply this. Say you have knee pain and you need to take a non-steroidal anti-inflammatory. Pick one: diclofenac, sodium, naproxen sodium, ibuprofen. You take those and they go down and they get into the stomach, and then they split into two. One goes to the pain, stops inflammation, stops pain. The other one hangs around in the stomach and releases, what's the name of it? It'll hit me. I can't remember. Anyway, there's a substance. It
Not
releases this.
not hydrochloric acid.
No. But it's
Okay.
it's an irritant inside the stomach lining that causes gastrointestinal weakening of the lining and potential bleeding. That's why people can't take it all the time.
Right.
One, because most of the NSAIDs will go through the kidneys. So you have to be careful of continued use because it creates more of an increase in hypertension because it's putting extra taxing on the kidney system to be filtered. But the irritations of the stomach lining come from the split.
Yeah.
Now, where Vioxx, remember that one?
Oh yeah, I do. That one was
It,
pulled.
right, that was pulled. That's a cousin to Celecoxib or Celebrex. Both of these were classified as these COX-2 receptor things. Now, what
Yeah.
that is they go down, and then all of them go towards the pain and inflammation, and nothing is left to irritate the stomach lining. The downside to this is that there is an increase in cardiac activity or irritation, what's the right word, side effect. And so the Vioxx was pulled off the market because it caused heart attacks.
Right.
My mom even was one of these that was on Vioxx and she had a heart attack. So, and then it was pulled shortly after that. So personal experience with these particular type of COX-2s. Now, Celebrex had not been associated with that, and so it's still on the market, and we still use it. Matter of fact, in compounding, I use it all the time. We actually make it, believe it or not, a transdermal gel mixed with Celecoxib plus lidocaine and other items for neuropathic pains, so we can apply it topically. But back to the system is the difference between, say, ibuprofen, which goes down and splits in two, one to irritate, one to work. These ones all goes to getting rid of the inflammation and the pain, and it doesn't stay around to irritate the stomach lining. So that is kind of the nutshell description of how Celecoxib works. Now, from a cancer standpoint, is where it really gets into it, and I think this is where you wanted to focus in on.
But I wanted to focus, and I want to focus on it as it relates, Joe, to particularly here surgery, because again, I think this is a step in because, when you look at these two medications, there's enough evidence to suggest that alone they can be repurposed in oncology. So Celebrex, obviously if somebody has pain with cancer, which is very common, it's the number one cause or number one pain or number one symptom related to cancer. You can add in something that helps with the pain and actually helps target the cancer because most aggressive tumors express COX-2. That's the selective nature that you were talking about versus the non-selective nature of ibuprofen. This is a selective receptor mechanism. Now, it works beyond that, but that's what it's doing here. Propranolol is the same way. But what they did in this, it's really interesting because they looked at surgery. Now, I call surgery one of the unholy trinity, surgery, chemo, radiation, because they're designed to go to war on the tumor and to reduce tumor burden, to reduce a large tumor that's there and reduce the overall tumor burden. Now, understand that concept is very important because it's impacting the immune system and the efficacy of therapy. And understand the key to cancer is the immune system. It's not just simply that stated, but if you can get the immune system doing its job, which is a lot harder, a lot easier to say than to do it, but if you can get the immune system doing its job, guess what? The work becomes much, much easier. And so surgery actually is a means that it can actually hurt the immune system. Chemotherapy hurts the immune system. Radiation hurts the immune system. And so these all may in the short term reduce the tumor size, the tumor burden, cut it out, you can't see it. And thus you're in quote unquote remission, but then it comes back maybe months later to years later. And so when we look at surgery, the question is, what are we doing? If we cut it out and then we set the stage for metastasis, is that really, are we really helping things? We're buying time for sure. We're hopefully getting to the next day where we can treat. But then if we don't manage that issue, then we could set the stage for metastasis. So the surgical stress is associated with, you mentioned the catecholamine surges, the epinephrine, norepinephrine. And what you get is you get a localized and a systemic immune suppression. You also mentioned aggregation of platelets. This is very important because in the process of healing, platelets are involved. Cancer has been described as a tumor that does not heal. Well, guess what? When you do surgery, you create it's a wound that does not heal. That's how cancer has been called, a tumor, a wound that does not heal. But when you look at surgery, it creates a wound. So when you're creating a wound and a wound that does not heal, it needs to be allowed to heal. And platelets are a big part of that. But propranolol is really interesting. Platelets bind to these circulating tumor cells and protect them as they circulate through the blood. So this is just another mechanism of how the propranolol can work here. But the immunosuppression of the surgery and then the process of that persisting actually increases the risk of local recurrence and metastasis. And it's interesting, when you look at colorectal cancers, 30% of colorectal cancer patients develop metastasis within 5 years following quote unquote curative intent surgery. Now, what's interesting about that 30% is 1 in 3 patients will develop cancer in their lifetime. So it's equal to the general population of developing cancer in the beginning. So it's like, what are we really doing with surgery? It's buying time. If we don't take the opportunity, or if we don't approach surgery in a better light, then we're not going to really set ourselves ahead where we want to be at 5 years, let alone 6 months. And so what they did, Joe, in this study, as you've, I'm sure, read, is they said, well, this is really interesting. Let's do something very simple. It wasn't a really crazy design study. They said, we're going to have 2 arms, one arm that's intervention and one arm that's not. And they're going to get surgery for colorectal cancer. We're going to start this combination therapy of Celecoxib 200 milligrams twice a day and propranolol 40 milligrams twice a day, 3 days before, every day, till 7 days after. And that's what they're going to, and so that's what they did. A very simple study design. And the results were crazy good. I mean, is that dosing out of line, or is that pretty much standard?
No, I mean,
Sorry, I said 7 days. They did it 14 days post-op. They took it out 2 weeks.
well, I mean, I don't know if it's standard, as far as dosing of surgery for cancer.
Yeah. Well, just in general.
Yeah, in general, I'll say, what was their dose here?
200 milligrams BID.
Oh, no, that's one of the reasons. I mean, yeah, that's standard dosing. Yeah, here's the thing. The magic word I was trying to remember earlier was prostaglandins.
Oh,
That's
yeah.
the lining of the stomach. This doesn't affect them. What's interesting, too, is if you're looking at this study that we're referring to, is this significant improvement of the tumor molecular markers of malignant and metastatic potential, and reduced epithelial to mesenchymal transition, and reduced tumor infiltration of CD4 monocytes and CD19 B cells, and increased tumor infiltration of CD56 natural killer cells. I mean, they went through all of these things that were positive of using this. And I think what's interesting about this is that they're doing studies. I'm not sorry, studies, but surgeries. And the idea is like, okay, this one section, your say gastrointestinal tract or colon, whatever is defective, so we'll just cut that piece out and then reattach it, and your problem's gone. I don't think they're addressing the fact that something went wrong for this to happen in the first place, and they're not treating the body as a whole. No. And saying, okay, where is the disease state coming from? What is the foods that you're eating back, taking it back to, say, growing healthy foods and regenerative farming practices. We're talking about synthetic medications. We're talking about processed foods and nutritional deficiencies that would lead to this. One of the biggest ones we're quite aware of is the level of vitamin D in patients. I remember talking to you years ago when you had a practice here, one day you came to me and you said, I tested all my patients in my practice for vitamin D levels. And you told me that the average was 20.
Yeah, they're all low. Yeah.
Right, right. And he says very few of them were above 20.
And
And of course, now we're pushing everybody to, of course, there was a study a while back, I forget how many years ago it was, and it says if you hit 47 nanograms per mil, then supposedly decrease cancer by 70, was it 77%?
yeah, but you need
And
to go up.
so now we're going even higher to 100 and 125 nanograms per mil
Yep.
on people with cancer. And the oncologists in Great Britain are seeing that cancers are responding to all treatments once you hit that level of vitamin D3. I think it was specific is what it was. But back to the use of Celecoxib in this is, which is interesting because it reduces the effective inflammation of COX-2. It reduces polyps by up to 46%, which I thought was really, powerful. To think that all we have to do, I don't know if all we have to do, but a simple addition of these two medications in the process of doing a surgery decreases this 5-year metastasis that shows up later. There was another one too that I was going to mention, which I thought was interesting because in the COX-2, it's right here. It says it's proven to be an anti-inflammatory, and there's some evidence it can be used as an alternative to the steroid dexamethasone. And the challenge with using steroids to shrink swelling and try to get that anti-inflammatory effect is an increased rate of sugar content, right? Which is
Or
driving what
immunosuppression. So when
exactly.
one of the mainstays of DEXA is, for example, brain metastasis,
Yeah,
and you use it because you can't have swelling in the brain. That's a closed confined compartment. You risk of herniation and
right.
acute events. And the problem is that research tells us that accelerates the growth. But it's basically something that you're kind of caught in a corner. You have to do something there. But that therein lies where a natural therapy. So think about this. Boswellia, right? Boswellia, they actually did a head-to-head study. We're getting a little bit off track here, but I think this is good. That where they did a
Sorry.
head-to-head study with Boswellia and dexamethasone in edema post-radiation, and they actually found that Boswellia was equal. The problem with Boswellia is you had to dose it at 2,000 milligrams twice a day, which is a heck of a lot. Makes it very spicy. But here's where I believe, because people say, well, these are still drugs, and you touched on that, Joe. They're controlled poisons. I think that was a very well crafted statement. And it's very true, but they're safe and we know how to dose them, but we can combine them with more natural therapies. So, for example, what if we had added Boswellia to this study? What if we were adding in not DEXA, but, Celecoxib plus Boswellia to work as an alternative to dexamethasone in cerebral edema? These are the kind of questions that we need to be allowed to ask. Unfortunately, in this concept of conformity of mind that exists today, we can't. But here on this podcast, we're going to answer them and we're going to see what we can find on it.
Years, I'll tell you an example of that. And because you're right. The question is, why don't we do this, or why isn't anyone actually trying this? There's no reason that you shouldn't, except that, I used to talk to docs all the time, and they used to tell me, and this was years ago, they would say, well, I don't write anything that's not FDA approved. As a compounding pharmacist, that's a tough thing to hear from a doc, because it's like, well, yeah, anything you're compounding is not FDA approved. I mean, you'd be using FDA approved chemicals and mixing something that doesn't exist. And the idea is to alter the outcomes, right? But if somebody says, well, all I use is FDA stuff, and it's like, well, you've got a very, very limited, range of tools to use. And that's changed. I mean, since COVID, people are like, well, look at how many times we threw the kitchen sink at COVID trying to figure it out. I mean, they're trying everything. And, that's where a lot of these things came up. So I think there's a little bit more open-mindedness now. Years ago, there was in this area, there's something called the CHEO that started, the Complementary Health Education Organization. And the idea, I don't know if you remember those guys, the idea was to take alternative practitioners and allopathic practitioners, and give them a forum to come together and talk about, the way we treat things from a regular medicine side and the way we treat things from an alternative medicine side, herbal or whatever, and to come together. And interestingly enough, and it's still in existence today. It's almost 20 some years. The problem is that there's very, very few um, standard medicine practitioners that go to this meeting. They're usually alternative people that are kind of on the natural side, and very few allopathic practitioners participate. So there has been an attempt for years to try to bring these two ideas together, because if they did, something like this might be done. Think about what Dr. Paul Merrick did with the use of IV vitamin C in treating sepsis, right? There is no FDA-approved medicine for sepsis, but yet he used a combination of B1 and corticosteroid and IV vitamin C.
Yeah.
And in 1 year's time, where he should have lost approximately 50 patients, he only lost one patient. And then I think the INH gave him like $1.6 million to continue the research. So they finally actually found something that addresses sepsis, and it turns out to be something as simple as IV vitamin C. Who would have known? And we have to look at this stuff. And I think we limit ourselves by ignoring them just because it's an herb. And it's like, okay, well, fine. Use Boswellia, shrink the inflammation, get the outcomes you're looking for, and let's move forward. Document this stuff and tell the world.
It's because what we're dealing with is an issue with profits over patients, and the profits are dominating the patients. But thank you for mentioning Paul Merrick. He's a good friend of mine, and dear guy, got a great heart. Just think the world of him. So shout out at Paul Merrick. Anything that he's producing, it's worth your time to read or watch. He's just a great guy. So let's dive back into the mechanisms here, because they go, okay, Celecoxib, COX-2 inhibitor, pain, propranolol, a non-selective beta-adrenergic blocker. How in the world do these help? So it's not enough to say, wow, this reduced metastasis, this reduced inflammation. How do you know that? What's the what there? And so what they found is that in this combination, again, 3 days to 2 weeks post, they found a reduction in matrix metalloproteinases. We'll talk about this in just a second. They found in matrix metalloproteinase type 2 and 9, a reduction in 47% and 53% respectively in the intervention group compared to the control. Again, we're talking about a randomized controlled trial here. So if you're a doctor actually listening to this, understand this is science. This is science. And what they also found is an expression of the tissue inhibitors of the metalloproteinases actually increased 2.3-fold. They found also a decrease in angiogenic factors. Now, angiogenesis is that blood vessel supply growth that so desperately cancer needs to meet its high metabolic demand. Vascular endothelial growth factor was reduced by 38% in the intervention group compared to the control group. Hypoxia-inducible factor 1 alpha just rolls off of the tongue this early in the morning. It actually decreased by 42%. This is triggered by hypoxia. So when cancer is growing really fast, it's outgrowing its blood supply. The vascular angiogenesis process is kicked in trying to meet that, and you have areas of hypoxia. That leads mutations. That leads immune dysfunction, disruption, miscommunication, etc. And so here, these medications associated with surgery, which is going to be involved with all this, is countering that in a very significant manner. And then you mentioned the epithelial to mesenchymal transition. People are like, ooh, what's that? Epithelial cells are cells that are immobile, more stationary, okay? Mesenchymal cells are cells that carry on characteristics that are more mobile and modal. And so there's certain expression proteins on them that can differentiate these type of cells. But the epithelial to mesenchymal transition is this process by which cells move from immobile to mobile. And so what they found is they actually found a increased expression of E-cadherin, epithelial, versus N-cadherin, mesenchymal, in these cells by a rate of 3 to 1. So what this combination medication did, 3 days to 2 weeks, It reduced the ability for invasion to happen, matrix metalloproteinases. It reduced the ability to meet the blood vessel supply growth and targeted hypoxia with the targeting of angiogenesis. And it reduced the ability to spread epithelial to mesenchymal transition. But Joe, you added in another one when you talked about propranolol and platelet agglutination, because there's what's called circulating tumor cell platelet aggregates, where these circulating tumor cells, which we know are released by surgery, okay, and what happens is they surround themselves with platelets, which buffers them from the sheer force of the blood and also buffers them from the immune cells, such as natural killer cells, as they're circulating. So there's a fourth. So here is not just, look, wow, it's helping. It's how it's helping. I mean, we're getting into the weeds of what this is actually doing in a randomized, controlled study.
Yeah, it's intriguing to me. I was really glad you sent this to me when I read it. I was very impressed, because I don't know how many patients we've come in the last month or so with colorectal cancer. So
I think this applies to all surgeries, though, but you have to say that it's limited here to colorectal cancer, because that's what this study was. But I think if anybody's undergoing surgery, Joe, I really think that this needs to be, I hate to use the word standard of care, it needs to be something that's considered by every patient and by every surgeon. But it gets even better, because the impact here is not just on those broad cancers. They actually looked at inflammatory markers. And so looking at the intervention group versus the control group, they actually found in the intervention group, there was a plus 32% increase in cytotoxic CD8 T cells. These are cells that will go and target tumor for destruction. They're called cytotoxic tumor cells. They kill cancer cells. They also found a 47% increase in natural killer cell activity. Natural killer cells do exactly what their name implies. They naturally kill cancer cells and other things. So what we have is a massive uptick in this anti-tumor innate immunity, but in the control group where they did nothing, they actually found an 18% reduction in the CD8 cytotoxic T lymphocytes, and they actually found a 23% reduction in natural killer cells. So we're talking about different, areas of the curve where the impact is. Now, what about harmful immune cells? Because I think this is important, Joe. A lot of people think, well, I want to stimulate the immune system, so that equates to good. I want to stimulate, or we have inflammation, that means bad. Actually, if you stimulate the immune system or you create inflammation, that can be good or bad. It doesn't equate to either. It's what the cells and what the signaling are doing there. It's like a chessboard. But what they noticed that in the intervention group, there was a 36% reduction in T-regulating cells. There was a 41% reduction in myeloid-derived suppressing cells. These are immune cells that get in there and they suppress the immune system. They suppress the immune system. Whereas in the control group, they had a 43% increase in T-regulating cells. They had a 65% increase in myeloid-derived suppressing cells. So you go in there and you cut this out. What you're getting is you're getting a massive influx, if you don't add this regimen in, of cells that are going to create an immunosuppressive environment. And if there's circulating tumor cells or any cell that's left nearby, guess what? The immunosuppression is going to allow those cells to retake, grow, survive, and one day pop up as a separate tumor. But let's say, well, how do we even measure these levels? That's very difficult from a clinical perspective. But what if we just measured some very simple measures? C-reactive protein, interleukin-6, and neutrophil to lymphocyte ratio. C-reactive protein in the intervention group was decreased by 62% after 3 days alone. Interleukin-6, a massive inflammatory marker, cytokine. It promotes, cytokine storm was very prominent in the pandemic, but it does the same process in chemotherapy, surgery, induced metastasis, radiation as well. 58% reduction at peak, both statistically significant. But then very simple, neutrophil to lymphocyte ratio, which is in a CBC plus differential. It needs to be actually differential, because otherwise it'll be just an automated thing. But neutrophil to lymphocyte ratio was reduced by 7.2 pre to 3.8. Now, why is that important? Anything greater than 4 to 5 is significantly negative in prognosis of metastasis and survival. So a very simple test via very simple combination of drugs during surgery reduced that neutrophil to lymphocyte ratio, which means two things. improved prognosis, which everybody wants, and improved survival. Boom. Why should this be done in every surgery, at least with colorectal cancer? That alone, I think, indicates that it should be. And we don't. Why do we need more studies other than it's just a way to pass it off and say I don't want to do it?
That's what I get. I read this and I'm like, this is night and day difference between the outcomes, and it's a no brainer. I mean, it just strikes me as, why isn't this being done all the time?
And this was 5 years ago. 5 years
Yeah.
ago.
There's another interesting situation. I don't know if I'll bring it up or not. You can cut this out if you want to, but
No.
yeah, I had a friend of ours actually had colorectal cancer, and she came to us and says, "Hey, they found me with colon cancer." So she read 14 studies, and she met with a doc. The doc says, "Hey, I'm going to give you some cisplatin, I think it was," and he was going, "I'm going to dose you this way." So she comes back to him, and she's a scientist by training, and so she says, "Well, the data suggest this protocol." And so the doctors agreed with her, and so he changed his protocol to match what she had found in 14 different studies. But she'd also found that cisplatin's side effect was drug-induced neuropathies. And so she put her hands in ice, and she put her feet in ice, and she put ice pack on her head every time she went in for an infusion. We're talking about basic chemo here. And so she didn't, of course, she looks like an idiot when she's in that room full of everybody else getting infusions. No one else was doing this, but she didn't end up with any neuropathy. And the idea is that, it cools down this area, so the blood flow slows down so it doesn't reach the tip, so it can do any of the damage to the nerve endings. And so she didn't end up with this as a side effect. But so many patients come in that have had similar experiences, and they're constantly, now their cancers, so the cancer's gone, but now they've got neuropathy they've got to contend with for the rest of their life. And I find that a shame, because I keep asking them when I go in there, I said, "Did your doctor tell you about cooling the appendages down and keeping some ice on when you do this?" And the answer every time I ask this question is no. And it's like, if the doctors know this, why are they not, or even the nurses for that matter, making this a standard protocol for all patients to go through? I mean, why? Okay, fine, they're getting rid of cancer, but they don't care that they're going to induce some sort of neuropathy. What a miserable outcome for these patients. So I just kind of throw that out there as one of these things where these things that we've talked about here are incredible and should be done, in my opinion, on every one of these surgeries to reduce the metastatic outcome that's going to have place in 5 years, possibly. And in the same sense that all these people that are maybe going to contend in using other treatments like chemo, let's cool them down, and just do some things that actually make their outcomes, a little bit more livable. Even if they, survive, they don't need to, not be able to feel or have all that burning and side effect stuff.
So anyway, let me take, people go, well, is this useful for everyone, or is it something that just is for colorectal cancer or very few people? Actually, high risk patients here would be, tumors that are expressing T3, T4, such as malignant pheochromocytoma or others. Because understand, when we think about hormones as it relates to cancer, we again are too simplistic in our thinking. Hormones can work on the front door. That's the nuclear receptors when we think about estrogen receptors, progesterone receptors, androgen receptors, but it also can work on back doors, which are non-nuclear receptors, what's called non-genomic signaling. It can be because there's elevated CEA. CEA, people would say, well, that's colorectal cancer. That is correct. That's a biomarker, but CEA is also a good marker for angiogenesis in general. So when you have somebody that has perineural invasion on some of the pathology. So the point is, there are patients here, inflammatory markers that are elevated preoperatively, but of course that requires that your doctors looked at that, which they don't. So there's plenty of ways that you could identify patients that would benefit from that. So if you're a patient and you're headed towards surgery, what I would say is the C-reactive protein, that's easy to check. The neutrophil to lymphocyte ratio, which is a CBC plus differential, those are easy to check. Get your doctors to check beforehand, because if those are elevated, then making the recommendation of this course could have a significant positive impact on limiting the negative impact of related surgery. Now, Joe, we've kind of went on a little bit, but why this hasn't hit the mainstream conventional cancer care, I think is beyond ridiculous. But what I hope here is that people will share this information, and it will incorporate into your clinical practice. It's already incorporated into mine, but then through the patients that you see, that can ripple out to other doctors. And of course, if you're listening or following online, you can actually share this with others that you would think would benefit from this, including your doctor or family or loved ones. So, Joe, help spread the word, dude.
I will.
Good to work. Good to work. So that's
It's-
it. That's why repurposed medications haven't hit it. You haven't done your job, Joe.
That's my fault. Sorry, guys.
I'm just kidding. I'm just kidding. You've got a lot of work to do.
Yeah, just doing drugs, living the dream.
Yeah. Well, how can, so again, in the show notes, this and other supporting evidence will be there. So I encourage you to check that out. Take the deep dive for yourself. Read the study. Yes, I know it's going to be a deep dive, but trust me, it'll cure any insomnia you may have. It'll put you right to sleep. But Joe, how can patients find out more about you, about your pharmacy?
Well, you can visit our website at freshdrugs.com. And we are Fresh Pharmacy, but our URL is Fresh Drugs. And if you need to call us, just 865-988-0000 or 988, ooh.
That's right, ooh. But I don't think that would work if you actually tried to verbally call with Siri. I have to try that.
Probably not.
That's it. Ooh, sorry, we didn't understand that. So, well, let me tell you what, on the next time you mention artemisinin, okay? And I did a hot take yesterday on the concept of artemisinin and artesunate versus, get this, ivermectin, okay? And this is a little bit of a tease, and I did a reel on this because you know who Chris Wark is, right?
No.
Chris Wark, okay. He had colorectal cancer, and he's in remission. Great guy, great story, great platform, giving people hope and help to tackle disease like cancer, and particularly colorectal cancer. He's a big advocate for the natural way, which is fantastic. Yet he said that ivermectin is going to be something that's going to go away, and we need to turn towards artemisinin because he said they're both antiparasitics, and they both won the Nobel Prize in Medicine in 2015. So we're going to touch on this in the next podcast. I'll send it to you. And those statements are true, but he extrapolated them out to faulty other conclusions. And so what we're going to do is we're going to dive into artemisinin, we're going to dive into ivermectin, and we're going to introduce a topic called artesunate. And we're going to talk about, are these the same? Are they different? Are they comparable from an anti-cancer repurposed medication? And I'll go ahead and let the cat out of the bag. They're not. They're actually probably synergistic, but they're actually different in mechanisms, but they are the same parasite. Just for a quick shout out here, our online course, our first module for repurposed medications in oncology, it is on metabolicregen.com. We will be providing future courses there as well. You're going to be able to hear me at NATIA's Metabolic Conference weekend. Again, it's going to be open to the general public as well as to doctors. And it's really interesting, Joe. It's going to be a mixture of farmers and doctors. You know, people talk about the restoration of the doctor-patient relationship. I think what we need is a doctor-farmer-patient relationship. And I think that is the way we could actually empower patients to live well, prevent disease, and actually treat disease from a natural perspective. So it's going to be a very interesting mix. You'll be able to see that again at metabolicregen.com, but also at the Metabolic Maintenance Weekend. Check out Dr. Natia Winters. That's where you'll find that. But also I'll be speaking a couple weeks after that at the Advanced Applications Medical Practice. That's Paul Anderson's oncology conference. I'll be speaking 3 hours there, Joe. Goodness gracious. But it's going to be awesome. Of course, I think the world of Paul Anderson at Paul Anderson. brilliant, brilliant guy when it comes to naturopathic oncology and just in general. And he has the best sense of humor. It's very dry. And so when he gets up there and I'm always in the back, I always typically sit in the back, but when he's talking, it's so funny because he says something that's very dry and humorous, and most of the people in there are a bunch of doctors, a bunch of stiffs. They don't get it, and I'm back in the back of the auditorium, falling out of my chair because he's just hilarious. But it's a very dry humor. So I'll be speaking at these two conferences. If you want to join us, that one's of course with Paul Anderson. That's much more of a doc conference. Come by and see us. So, and of course, this is the Off-ScriptRx podcast, where you can find us at off-scriptrx.com. I encourage you to share this with those who could benefit from that, including your doctor, your friends, your family, your loved ones. And this is Dr. Goodyear and Dr. Joe Nowell, and we are just two doctors. What are we, two doctors?
Doing drugs.
Yeah, doing drugs and talking drugs, and we'll see you on the next OffscriptRx.
That's right. Yeah, I'll take care.
Your health deserves more than a one-size-fits-all approach. Subscribe now and share this episode to help others break away from outdated treatments. Visit OffscriptRx.com to see how repurposed medications can fit into your personal cancer care strategy. Don't settle. Take action and join the movement to rewrite the future of medicine. Rethink repurposing medications. Rethink reality.